I'm sure you have already participated the first part of this presentation. So today we are mainly focused on the management of these so-called chronic lung diseases in children. First thing, as I mentioned last time also, there's no specific entity or term called chronic lung diseases. That is, we have to because there's no single diagnosis like chronic lung diseases. Or if there's because of that, there's no classification of chronic lung diseases or so like that. We generally term this chronic lung disease, use this term of chronic lung diseases with children with recurrent respiratory. So it's mainly maybe recurrent or maybe persistent respiratory symptoms. So most of these children are having bronchiectasis. So bronchiectasis is the one of the main thing which give rise to this type of recurrent symptoms. And some may have obstructive airway disease, and those children also finally end up with bronchiectasis. So when we are going on, I'll discuss.
No,
And
it's okay.
other important thing is we have different etiologies. Most of the time, conditions are different, but most important thing is when the management wise, most of them follow a common path. So because of that, almost all these conditions, which we generally use the terms as this type of chronic lung diseases, the management approach also almost same except for few specific diseases like cystic fibrosis, pancreatic enzyme supplementations, and the path also, the complications of the diseases and the final outcomes also almost same in all these diseases. As we discussed last time, there are various etiologies of these chronic lung diseases. I'm using the same term because that's a term that we are using. But most importantly, just keep in mind, we have to have specific diagnosis as much as possible, especially if you are dealing a case at the exam. So it may be chronic lung disease of premature, the BPD, or congenital structural anomalies, aspiration syndrome, cystic fibrosis, primary ciliary dyskinesia, bronchiolitis obliterans, childhood interstitial lung diseases, immune deficiency disorders, and some sort of pulmonary manifestations of systemic diseases. Or there may be some other secondary causes like alpha-1 antitrypsin deficiency or protease inhibitor deficiency, very rare in these type of thing. And some localized obstructive diseases leading to bronchiectasis like foreign body aspirations, tumors, or lymph node causing this localized obstruction, and some sort of congenital tracheobronchomegaly. These are also very rare. And sometimes this is further worsened with some secondary things like ABPA or maybe eosinophilic lung diseases. Sometimes very rarely can have this type of toxins or aspirations, or sometimes whatever the sophisticated investigations, genetic and all these things are available, sometimes about one third to one fourth of cases, diagnosis or the etiologies sometimes very difficult to diagnose, or this is termed as idiopathic bronchiectasis. Obviously, there might be some causes for this, but still, at the moment, with available techniques, some children with bronchiectasis, we are even in the developed settings, we are not able to identify exact etiology of these bronchiectasis. That is called idiopathic bronchiectasis. So we discussed these etiologies in details last time, and especially how to identify these things. There are different specific especially specific factors related to the different etiologies of these conditions. So you have to have some idea about these different etiologies, especially at least the first 7 to 8 causes which are little common in our day-to-day practice. Other important thing is, just to recap, this bronchiectasis in chronic lung disease, as I mentioned, most of the time, although the differential diagnosis or etiologies are different, usually they follow a same path. One of the important complications or the things which determine the outcome is bronchiectasis in these children. So bronchiectasis, it's mainly as a result of this vicious cycle. So there are some host factors, pathogen factors, and sometimes it's modified by childhood vaccines, and sometimes with other factors like anti-inflammatory and antioxidants. Those are the part of host factors and all these things. Sometimes these mucoactive agents that we are using as a therapeutic modalities and nutritions, all these things are important to finally shape the or decide the final outcome of these children. So because of these underlying diseases or maybe immune deficiency or some sort of other things, they can have high chance of developing infections, and these infections leading to airway inflammations, and these airway inflammations produce a lot of secretions and a lot of inflammatory mediators and produce mucus, and this mucus would be a good culture media for these microorganisms and again lead into infections. So this simplified vicious cycle. So initial insult may be due to one of the etiologies that we discussed earlier. Whatever the things, most of the time they follow this common path, and this insult, it may be infection or some sort of other things leading to inflammation, and these inflammations affect the airway. It's loss of the ciliary functions, the loss of structure of these bronchi and dilatation of the bronchi, and because of that the mucus accumulate. This mucus accumulation leading to again infections. So these infections again lead into inflammation and further damage, and so this vicious cycle goes on as a main determinant of the outcome of these children with this type of chronic lung diseases. Especially these bacterial colonizations. Usually we use this term, this bacterial colonization, but we cannot ignore them as colonizers, because if the bacteria are there, that means they produce some sort of even subclinical inflammatory process, even though there are no evidence of acute infections. Child might not have fever or inflammatory markers would be negative, but still, if the bacteria grow, they are residing within the airway, that means it might induce some sort of long-term chronic inflammatory process, and which will accelerate the disease progression as well as the development of further bronchiectasis. Other important thing is this mucus. So this mucus contains a lot of cells. These cells produce a lot of proteases, and these proteases also again leading to the tissue damage. So that mucus damage this thing by two ways. One thing is it acts as a culture media, especially these organisms can grow there and finally induce some sort of long-term chronic inflammatory process as well as acute exacerbation. Other thing is this mucus contains a lot of inflammatory cells, and those cells also can accelerate the lung damage. So this vicious cycle is very, very important just to keep in mind. Right. So that is just to recap from the previous presentations. So then when we are focusing on the management of these children, so it's important to have evaluate the children. So we discussed the history and examinations in little detail, but we don't have time to recap, but just to inform or discuss special important points. So how do we or why do we suspect a child who is whether this child is have chronic lung disease or some sort of chronic respiratory involvement or especially bronchiectasis? Because these children present in with recurrent or persistent respiratory symptoms, which requiring recurrent hospital admissions, and usually with the diagnosis of pneumonia or maybe wheezing-like episodes, or we may diagnose as infective exacerbation of the underlying chronic lung disease. And most importantly, these children, especially with established bronchiectasis, they are symptomatic in between these two episodes as well, in between episodes. So they have intermittent acute exacerbations, usually settle, but there is no complete resolution of the symptoms. Once this bronchiectasis is established, they would have in between symptoms as well. So when we ask, especially from parents, the how many days of whether when we consider the last few months or few years, whether the cough, the days with cough, or the what are the more dates, whether it's with cough or without cough, and most of the time they are telling the child had days with cough more than the days without cough. So that is indicative of some chronic lung involvement. So it's mainly persistent moist cough with sputum production the amount and color of these sputum would be vary according to the degree of bronchiectasis as well as degree of resolution of symptoms, as well as most importantly possibility of developing or ongoing exacerbations. So exacerbations can be identified clinically in early, most of the time, with the change of pattern of the sputum production, especially the amount of sputum production. I'm sure you know these things. Okay. So other thing is evaluation. So if the child presents, sometimes might be the first presentations, undiagnosed chronic lung disease, when the child is coming to you, this child might have a history of recurrent hospital admissions, recurrent respiratory tract infections with baseline or in between intermittent symptoms. Plus, if you examine these children, they might have growth failure or failure to thrive, especially finger clubbing and some sort of chest deformities. So especially when we consider these chronic lung diseases, because of this impaired or the lung functions, the body is trying to improve or increase the tidal volume. So when this process is going on, the chest is hyperinflated. It may be due to obstructive airway disease itself can cause, or long-standing parenchymal involvement also leading to the body trying to get more and more air by increasing the tidal volume. So action of these accessory muscles and the changes finally end up with barrel-shaped chest. Usually what we are using this term of pectus carinatum. Mainly important thing is increase antero-posterior diameter. Oh, and we can see this Harrison sulci. So if a child presenting with these chronic symptoms as well as evidence of physical evidence of this chronic lung disease or chronic respiratory involvement, then we have to consider further evaluation of these children. Clinical evaluation, this is especially important at the exam also. If a child has persistent moist cough with sputum production, finger clubbing and examination reveal cause crackles, cause crepitations. If this triad is present, so that is almost diagnostic of bronchiectasis clinically until proven otherwise. So it's this triad is almost always indicative of bronchiectasis in these children. Without seeing a CT or chest imaging, you can clinically diagnose these children. Exception would be some sort of rare cases. Most of the time, they should have bronchiectasis. So remember this triad. So other thing is the progression. As I mentioned, despite the different, we discussed about 12 to 13 etiology, but there would be more. There are some other rare cases, the rare causes or etiologies. But despite all these things, most of the time, the usual progression, the pathway of these diseases, these illnesses, or with what we termed as a using this blanket term, the umbrella term, this chronic lung disease, the progression, the pathway they following the progression is almost same. So there are conditions with airway obstruction. The disease per se leading to airway obstruction, like bronchiolitis obliterans. As you know, it's involved the small airway, some sort of fibrotic changes, peribronchiolar changes, and there are some obstructive changes within the bronchiole. So because of that, disease itself leading to airway obstruction. Cystic fibrosis, as you know, is leading to thick mucus production. Because of this thick mucus, disease itself causes airway obstructions. Primary ciliary dyskinesia, again, disruption of the normal mucociliary function. There are a lot of retention of mucus and the inflammations and infections. So all these things leading to, again, mucus retention and airway obstruction. So these disorders from the beginning might show evidence of airway obstruction. And the recurrent infections, the immune deficiencies, obviously it's leading to immune deficiency, leading to recurrent infections, especially for our point of view, sign of pulmonary infections, cystic fibrosis and PCD, obviously because of this poor mucociliary clearance leading to recurrent infections, and bronchiectasis. Once the bronchiectasis is developed, as I shown earlier, it's itself leading to infections. So these diseases they have recurrent infections. And there are some diseases, since beginning, they might have hypoxia. The classic thing is interstitial lung diseases. The interstitial lung disease, these are, as we discussed last time, it's some sort of specific conditions There are some specific conditions like surfactant protein deficiency, uh, a neuroendocrine cell hyperplasia of children, or maybe pulmonary interstitial glycogenosis. These diseases just involve the lung parenchyma. So the gas exchange is directly impaired, and those are usually diffuse disorders. Diffuse disorders, both lungs, all lobes are involved. So because of that, since beginning they are hypoxic. Without developing bronchiectasis, they are hypoxic. And later, other diseases, when they are developing significant bronchiectasis, I will show you some pictures. All the bronchi, majority of bronchi are dilated. So because of that, the lung parenchyma, lung tissue, the tissue available for the gas exchange is significantly reduced. So obviously end up with significant ventilation perfusion mismatch and hypoxia. So when this hypoxia is going on as like that, so most of these conditions finally end up with hypoxia. The problem is initially this hypoxia is subclinical. Child might not see or show any evidence of hypoxia, especially the first manifestation of hypoxia usually develop while during deep sleep. All of us, as you know, the respiration get depressed during deep sleep. The muscle activity or the ventilation drive get depressed. But in normal people, that might not be causes significant problem. But if the child is already hypoxic, already compromised ventilation, already compromised diffusion, or already compromised ventilation perfusion, so then they, while normal thing happening while during sleep, so they end up with hypoxia, but might not detect early. So they might show evidence of sometimes poor quality sleep or evidence of lack, or like we see in the obstructive sleep apnea syndromes. And then if this is progressive, obviously they show evidence of hypoxia with exercise or some degree of physical exertion. That is mainly they show evidence of breathing difficulties, progressive breathing difficulties, or children, when they develop breathing difficulty or when they develop hypoxia, they themselves try to restrict physical activities. Though the clinical manifestation is gradual restriction or gradual avoidance of physical exercise or physical activities or the reduction of this degree of exercise. And then later, the final stages, they show resting hypoxia or resting stage also, they show significant breathing difficulty or breathing issues. So when this hypoxia persisting, obviously, you know, there are some changes happening in the lungs. The response to hypoxia in the lung is vasoconstriction. Try to divert the poorly ventilated blood, the areas, the blood supply to the poorly ventilated areas to the normal areas to significantly reduce the VQ mismatch. That is some sort of physiological adaptation. But when this is process is going on, the intimal changes, the wall changes develop within this vascular structure of the pulmonary circulations, as we discussed last time. This is leading to pulmonary hypertension. So when this pulmonary hypertension is untreated or undiagnosed, is progressive, child end up with copulmonale. So this is the usual common pathway of progression of this chronic lung disease, whatever the underlying etiology. So this is very important. We have to identify if we have a child, if we get a child, especially for the first time, what stage with this child is on, which complications this child develops. So this is a part of evaluation. So this is important to identify or have some idea about the natural history of these chronic lung diseases in children. So then evaluations. So what are the important things we should focus while evaluating these children? Assume this child we are encountering the first time in our life. So then, or it might not be already evaluated, or sometimes already evaluated, but you need to start all these from the beginning. So what are the areas you should focus? If a child show, as I mentioned earlier, evidence of some sort of chronic respiratory involvement, so first thing is we have to consider what is the etiology of these conditions. What is the etiology of why this child develop this much of significant respiratory involvement? And then we have to have some idea about the current status. So current state include the complications as well. And sometimes there are associated conditions. These associated conditions may be directly related to these things. So, for example, child might have neuromuscular disease. So, or maybe secondary systemic disease. So, that is directly related to this thing. Or sometimes there might not be directly related, direct relationship with the current respiratory disease. But all these are important in the overall management of this child, because we are not just managing the lungs. So, we are managing the child with lung problem and the functional impairment. So this is also important to get some idea about the current status and the plan the further management, especially to improve or at least support some degree with this functional impairment. And then finally, we should have a very good idea about their social background, all these things, their expectations, their knowledge about the disease, their education level, their economical aspect, social supports, because most of these chronic lung diseases, once this established, they are not reversible and usually follow a deteriorating path. And someday, child might need some sort of a sophisticated support. So for that, child might have very sound family support plus sound economic background to maintain the ideal management, which is usually it's a challenge in our setup, and usually we are failing to support or provide the ideal optimal support. But so it's that is also important to get comprehensive analysis of the social circumstances of this child. Etiology. So how do we evaluate the etiologies? I am not going to the details of these things as we discussed the different conditions last time also. This is just a theory, but just to have some idea, obviously history and examination is important. Sometimes history itself might give the diagnosis. For example, chronic lung disease or premature bronchopulmonary dysplasia. If a child is a premature child who required oxygen supply due to prematurity for 28 days, by definition, that child should have BPD. So the history itself is diagnostic. And examination, sometimes you might see chest deformities or maybe secondary causes like systemic diseases or neuromuscular diseases. So history and examination is very important. Sometimes that itself give the diagnosis or the underlying etiology. And the chest imaging. So chest imaging also important for the diagnosis wide etiological diagnosis as well as identification of the complications. And immunological assessments. So these are the tests we do as a series. Obviously, we have to exclude or if there is no obvious diagnosis, we have to exclude possible immune deficiency disorder. Sweat chloride test to exclude cystic fibrosis if the clinical picture suggestive of cystic fibrosis. But still, even if there is no clinical history, we have to do sweat chloride test, especially if child is having evidence of bronchiectasis. And stool elastase to identify or confirm the diagnosis of malabsorption, which is not available in our setup. And genetic assessment is important to have some sort of proper diagnosis. For example, cystic fibrosis, some conditions like interstitial lung diseases, or maybe PCD, especially these genetic disorders, or some recessive disorders. Upper GI contrast studies or meal scans if you suspect some aspiration syndromes. But as I mentioned earlier, to have a chronic lung disease due to aspiration syndrome, child should have significant thing. It may be initially repaired esophageal atresia, or maybe history of tracheoesophageal fistula, surgical interventions done, or some sort of anterogate aspirations due to neuromuscular conditions or CP-like condition. And other specific diagnosis like PCD, primary serial dyskinesia, the nasal nitric oxide level. In PCD, this nasal nitric oxide are significantly reduced. That is a screening test. And the diagnosis is with electron microscopy with nasal brushings, which is not available in Sri Lanka, but you should have some idea about the ideal situations. And if you are suspecting systemic disease, specifically important to do the work of like SLE or rheumatoid arthritis or something like that. Obviously, according to the clinical suspicions, we have to extend the investigation panel. So that is mainly to identify the etiological diagnosis. Then the evaluations of we have to assess, do the further investigation, so the further assessment to assess the complications associated conditions, and the functional impairment. So I'll discuss these things while assessing discussing the management or the assessing the progression of the disease. Okay, so one thing is important in this respiratory medicine is chest imaging. You also should have some idea to how to, especially to identify the changes in a CT scan. Chest X-rays obviously is very important, but most of the time to get a specific diagnosis or some to have a specific idea about the lung situations, we should have a CT. So the ideal we are using this HRCT, high resolution CT, but have to differentiate what is the difference between this HRCT and contrast CT, because HRCT is high resolution doesn't mean it is a superb investigation. High resolution CTs mainly focus in the lung parenchyma. If we assess or if we suspect, especially to assess the bronchiectasis or some changes in the lung parenchyma, we should do the HRCT. But if you want to assess, say, lung collapse, obstruction, airway problem, or especially mediastinal uh, abnormality, especially we suspect mediastinal lymphadenitis or airway obstruction, you have to do a proper contrast CT. Now the MDCT machines are available, same machine, the same time, the machine can reconstruct both. While doing contrast CT, the machine can do the HRCT as well. So this is this CT, you can see there are a lot of changes are there. So this is bronchiectasis changes with the collapsed lung. So this is lower lobe, collapsed lower lobe, and hyper. So this area looks like normal, and you can see this mosaic pattern. You can see the black area as well as white area. So that is called mosaic perfusion, some dilated bronchi, and so all these things are important diagnostic or the CT descriptions. The ground glass is some sort of opacification, but the difference is ground glass and the consolidation is consolidation is the alveoli are completely filled with something most of the time, inflammatory or exudative materials. The ground glass is alveoli are partially filled with some sort of inflammatory materials, or even it may be bleeding. So the ground glass appearance, we can see the vessels. So these are the vessels. But consolidation, we cannot see the vessels. So that's a difference between the ground glass appearance and the consolidation. But the disease processes are same, would be same. And you can see here, you cannot see this is a consolidation as well as collapse. Now you can see there are areas of bronchiectasis, some is honeycomb-like appearance, but cannot see any vessel. Right. So other important thing is identification of bronchiectasis, as I mentioned earlier. So lung damage leading to the significant damage to the bronchi, dilatation of the bronchi, and the permanent dilatation leading to this type of areas which dilated bronchi. And sometimes, so this is a longitudinal cut, this is a transverse cut. With this cut, you can see the ideally bronchi should be taper off while it's going to the peripheries, but if they are dilated, it might almost, it goes almost parallel till they go to the peripheries. So that is one sign of bronchiectasis. Other sign is dilated bronchi. But the important thing is, because bronchi, normal bronchi also there, how to identify that this is dilated or not. So that is classically with this signet ring sign. So signet ring is all the bronchi are associated with adjacent vessels, the pulmonary artery. So this is the pulmonary artery and this is the bronchus, adjacent bronchus. The diameter of these pulmonary artery and adjacent bronchus should be almost equal. It's about 0.8, but it should be at least 1 to 1. But if the bronchus is dilated more than the adjacent pulmonary artery, or the diameter is increased, that means it is dilated. So that dilated thing forms this signet ring. The gem of the ring is the normal pulmonary artery branch, and the dilated bronchus is the ring of the ring, whatever the things. Okay, so right. Again, you can see this type of significant lung damage can happen. So when this type of significant lung damage, you can clearly see the area, the normal lung parenchyma available for the gas exchange is significantly impaired, and obviously end up with hypoxia in these children. Okay, so then how do we manage? What are the principles of management of these children? Once the lung damage, especially bronchiectasis, is established, no one cannot reverse these changes. So they are permanent changes. So once we identify or once we get a child with this type of so-called chronic lung disease or bronchiectasis, then from that onward, our plan of management is to facilitate lung growth and maintain pulmonary function. That is one of the most important thing. As much as possible, preserve the lung functions. As much as possible, preserve the lung growth, because we are dealing with children. They're growing children, so lung growth should be definitely there. And allow near normal life as much as possible. Although they have some issues in the lung, we have to allow as much as possible near normal life as other children. They should be able to play, run, swimming, have bath, normal foods, including cold foods like ice cream, all these things as much as possible without undue restriction. They should be able to do all these things because we are dealing with children. Another important thing is prevent further exacerbations, because exacerbations accelerate this vicious cycle. Obviously, it might lead into the further worsening of this condition. So the prevention of exacerbations as much as possible, we might not be able to totally prevent as much as possible. Prevention or at least delaying this exacerbation also another important thing. Another important thing is, most important thing to all achieve all these things is the prevent or delay the complications. As I mentioned earlier, it is very difficult to prevent the progression once the bronchiectasis is established. So our main objective of the management is to delay the complications or delay the progression of this disease. That is the main important thing, our focus of all this management to achieve all these things: lung growth, normal life, pulmonary functions, all these things, prevent exacerbations through the delay in this progression. While achieving all these things, other important thing is to, with minimum or no side effects of drugs. If you are using long-term drugs, we have to achieve all these things with no or minimum side effects or adverse effects. So these are the usual principles of management of children with chronic lung diseases. Right. So first thing is management. We mainly focus about this airway clearance. So why it is important, especially when the bronchiectasis is already settled or already established. You can see, so these are the normal airways. Once this bronchiectasis is established, you can see this type of very damage, significant damage to lung and areas of, sometimes when the sputum filled with these areas, especially the sputum, sorry, the mucus. So there are lakes of mucus. Lungs are filled with this type of areas of mucus. And especially conditions like cystic fibrosis, the thick mucus, or even PCD. But not only these conditions, when there are a lot of areas to stagnate, then the mucus can stagnate in the airways, especially this bronchiectatic airways. And when this actual damage happens, this type of patients, so significant damage, so it may be localized or sometimes generalized damage. So you can see this time the honeycomb-like appearance. All these things are areas are dilated bronchi and sometimes associated with necrosis of the lung as well. So when this is a normal airway, so you can see very clearly the secretions can escape through this normal airway. But like cystic fibrosis like conditions, PCD, any of these conditions, once the bronchiectasis is established, the areas are filled with mucus. So we have to get rid of this mucus. So airway clearance is very important, as I mentioned at the beginning of these presentations, due to several reasons. So we have to get rid of this excess mucus. So what are the principles to get rid this of mucus? So we have to ideally get some air column behind this, and this air column should propel this mucus into the proximal airways. Once we bring this mucus into the proximal airways, then the child can cough it out. So the main purpose of this all these interventions to bring the mucus from the peripheral airways into the central airways. So what are these techniques? This is joined just briefly. Now I'm not focusing on the great details, but this is I am focusing because now we are managing these children. They are using these type of some sort of new techniques also. If you identify a child with this type of things, or maybe in a, while working at a peripheral hospital or even at an exam, so it's better to have some idea about these principles of these airway clearance techniques. So there are independent techniques. That means child or person himself, herself can do some techniques. One thing is breathing techniques. There are some breathing techniques. It's involving lot of physics, not the physiology. Some physics. The with lot of breathing techniques. That's to control breathing. That is to control the tidal volume to bring the mucus because of that during expirations airway get collapsed. That is called equal pressure point. This equal pressure point we can change the equal pressure point. So with that we can bring the mucus into the proximal airways and cough it out. So there's another one called this active cycle of breathing techniques. The patient can himself do these things, especially if in a older children. So other independent method is postural drainage. If there is localized bronchiectasis or localized the mucus, the production and stagnation with the assistance of the gravity without any person or the without assistance of in a person, the patient himself can do this postural drainage techniques. But the thing is, it will take little time. Various positions can be adopted to drain the this mucus into the proximal airways, and with that then they can huff and cough it out. Like that, various positions can be used. And the dependent technique. So dependent techniques, we have two methods. One thing is the therapist dependent, and other techniques are the devices dependent. So therapies means it not only this physiotherapist, but whatever the person who are capable of giving this. Most of the time the parents are the persons or the therapists which give this physiotherapy or this percussions and the some sort of airway clearance to especially small children. So important thing is use this clasped hand. The amount of air retained within the clasped hand vibrates. So that is the important thing to generate some sort of waveforms which lead into the disintegration of the mucus. The purpose is disintegrate mucus and allow this mucus to drain into the proximal airways, and then child can cough it out. So that is the principle of doing all these things, percussion techniques and the vibrating techniques. So we can use the class hand as well as these percussors, like these type of specific devices are there. As we don't have these devices, for example, if we want to do a significant or vigorous percussion or some sort of chest physio for especially child in ICU setup, we can use a ambu face mask. That face mask, ambu mask, though the bag mask, we can occlude the hole in that mask to connect to the ambus with some sort of cotton and use it as a percussor. So these are the percussion techniques. And there are different devices. We can use these devices. Especially the principle is there are two types of devices, PEP devices, to provide some sort of positive expiratory pressure. So very simple method is to we can use this face mask, and this face mask is connected with this type of valve. So this valve can change the resistance to the expirations. With this resistance to expiration can produce some sort of positive air expiratory pressure. So this is important to improve the collateral ventilation, especially dilate the collapsed airways. Especially this important to get some air column behind the mucus plug. So that is important to facilitate the airway clearance or push the mucus into the proximal airways. Those are the positive expiratory pressure devices. Like that, there are simple devices are there. So here this device, the rotating this thing can change the pressure. And there are PEP devices, oscillating PEP devices like this. So it contains some devices contain the a magnetic ball which is vibrating or oscillating while expirating, or there are some lung flute like thing, or this a cappella like devices, or aerobica. Those are all the trade names. This is a Platter device. So important thing is this produce both PEP because it provides. So some of you might have seen this a cappella device. It's contain valve like thing in the other part, the distal part. We can turn it and we can change the resistance. So that produce PEP, positive expiratory pressure, as well as this device contain the some magnetic ball. That ball is vibrating, that produce some sort of oscillating waves. So this is almost similar as we are giving this percussion. So percussion, the disadvantage is it need the therapist or another person, but the same these devices, the same percussion wave can be produced through the airway without the involvement of assistant or the therapist or the parent or whatever the person, the child or the patient himself themselves can do the chest tissue against same devices. So they have to blow or expirate through this device. And there are some devices as the therapist doing. There are some jackets, so they call high frequency chest wall oscillation. The West devices. This device is connected to a machine, and this because of that machine and it contains some air within this jacket. It vibrates. So these vibrations with high frequency, maybe they are using 5 to 20 hertz vibration, same effect but to produce some sort of vibration, and that facilitate the disintegration and the breaking of this mucus plugs, facilitate the clearance of airways. And the same principles we can use, and our setup we are using with this the bottle PEP devices. Simply we use a bottle, or the we can turn it as a bubble PEP using the soap water. This is especially small children, but that is not essential thing. Only thing is we have to have some sort of liquid, so water would be enough. We fill this with 10 centimeter water. So child and the end of the tube should be in the bottom of the bottle. That means child has to blow against 10 centimeter water column. So that is the PEP. So PEP is 10 centimeter water. And while blowing, it produces bubbles. This bubbling causes some sort of vibration, oscillating waves, and that is transmitted to the lung, and so almost similar effect as used in the device, PEP device or the oscillating PEP or a cappella device. So our setup also we are using this. See, this is very simple machine. Once they are used to do this, no need to use the soap water. But small children, we can use a small the soap water, and then we can ask them to blow bubbles. But the only thing is, small children, they should not aspirate this. They should blow through this. They should aspirate through this, but they should not inspirate through the mouth through this. So that is because of that we cannot use this device since very small children. Right. And apart from that, there are adjuncts, airway clearance. So bronchodilators. If there is a reversible airway component, dilatation of the bronchi again obviously facilitate the airway clearance. And there are mucolytic agents which usually we nebulize with these agents before giving the PCO or the airway clearance. The hypertonic saline is the simplest one we are also using in our setup. Usually other countries they use 7% saline, normal saline, sorry, not normal, 7% saline or 7% sodium chloride. Our setup we are using 3%. There are some studies they have proven that it's 7% or 3%, the effect would be almost same. The principle is the hypertonic saline, when we nebulize, it's increase the osmosis within the airway and it absorb water from the airway lumen, and that improve the or increase the hydration of the mucus and reduce the thickness of the mucus, and that's produce airway clearance. And the same osmotic effect can be obtained through mannitol, and there are dry powder mannitol preparations available. And the DNase, ACE means, as you know, it's an enzyme. So enzyme breaking DNA is like this donase alpha or pulmozyme that break the the DNA or the nuclei within the cells. As we know, the mucus contain lot of cells. As you know, if we want to take a good sputum sample, our microbiology report they mention it's a good sample if the pus cells contain more than 20 like. So that means pus cells. Its mucus contain lot of cells. If we can break down these cells, then that reduce the thickness of these mucus. So simply we can break down the mucus. So because of that, the DNAs is available as nebulizer things, and other countries they use this mesh nebulizer, not the routine our the jet nebulizers. So with this mesh nebulizer, within 30 seconds to 1 minute, nebulization of this drug could be completed. And this machine contains some program also. Because of that, doctors or the healthcare persons can download the amount that delivered. So that is also important to identify the adherence or the compliance to medications. That type of sophisticated and some sort of advanced methods are using. Especially when you are going for protein training, you might obviously encounter these patients with using this type of complicated devices. And the N-acetylcysteine, again, another thing, but this is now almost out in other countries because the effect is less. And there are some other things like the carbocysteine, like we are using in our setup, some sort of brand names I don't want to mention. But again, the effect is the carbocysteine also not that much proven, so most of the time it doesn't work. Right. So that is airway clearance. So the one of the most important thing to prevent or the break the cycle of infections implementing bronchiectasis and infectious inflammation bronchiectasis cycle is to clear the airway, prevent the or the delay or reduce the colonization of these organisms as well as the more damage. So airway clearance is one of the most important option in the management. So this we have to start since the beginning, since the diagnosis like CF cystic fibrosis like conditions, because it's itself the disease itself associated with thick mucus need airway clearance. But some other diseases like interstitial lung diseases or bronchiolitis obliterans or recurrent aspirations, once they develop bronchiectasis, then we have to start. Otherwise, without bronchiectasis, no point of doing airway clearance. Another important thing to prevent or the break this cycle is prevention and management of respiratory infections. So it is very important to identify these possible exacerbations, especially the infective exacerbations early. As I mentioned earlier, some sort of clinical clues. One thing is child growth might not be happen as you should. Second thing is change in the sputum production, the amount of sputum production as well as the change in the color. So these are important to identify and early detection and early treatment, especially if they present with acute infection. Early and vigorous treatment, especially if the child is having pseudomonas infection, we have to use two anti-pseudomonal antimicrobial. And most of the time in acute stage, we have to treat with IV antibiotics. And usually it's a prolonged course, not few days, at least 2 weeks of IV antibiotics. In other countries, even though they don't have acute exacerbations, once they have established bronchiectasis, 3 monthly IV antibiotics, 3 monthly, 2 weeks of IV antibiotics, such a vigorous treatment we have to give. Other thing is regular checking of the sputum or cope swabs, sputum samples or cope swab. Cope swab is we use the swab same as we are using for the swab in the for the COVID. The scope soap we keep ask the child to open mouth and keep without touching the throat. We keep the soap in within the mouth, especially as far as possible. We have to send it to the throat, but without touching the throat, and we have to ask the child to cough. With that, if there's an organisms without touching, because most of the time the thing is the normal flora, especially the upper airway flora might contaminate, but with this technique, with the cough, it's directly coming through the lungs. So that is one important thing to identify organisms. That's a very simple method, but cannot do these days because of this COVID situation and not done in anyway our country. And the sputum. So those are very important. Another thing is treatment, long-term treatment if there's any colonization. So there's no such a thing called colonization because once the organisms are there that induce most of the time long-term inflammatory process. For example, you can see cystic fibrosis. The different organisms colonize. The initially mainly the first 3 years of life, Staphylococcus aureus, especially first 5 years of life, and then gradually Pseudomonas. When they are growing older, almost all of them, here I mentioned as about 80%, but most of the time in our setup, they colonize with Pseudomonas. For that type of situations, we have to use long-term antimicrobial like tobramycin, colistin, aztreonam, and those are specific nebulized antibiotics available, and they use the alternative. This month tobramycin, next month colistin, again tobramycin, like that, to prevent the development of resistance to these antibiotics. Another important option is use of immune modulators. Use of immune modulators. Uh, we are using azithromycin as the immune modulator. So this is mainly used. There are a lot of mechanisms. Actually, we use this as a part of antibiotic. It's prevent the development of the some sort of organisms like the colonization of pseudomonas-like organisms. But at the same time, there's a risk of developing resistance to this as well. But another important thing is it's involved in the lot of pathways. I'm not going to details. So this is one you can see. So this molecule can interfere with lot of cellular mechanisms, especially involved in the inflammatory pathways. It is not an immune suppressant. It doesn't suppress the immunity, but it's an immune modulator. That means it alter the exaggerated immunity. So that is the most important thing. So we are using 10 milligram per kilogram azithromycin per day, 3 days per week. That's a usual regime which used in Western countries as well. And duration, no one knows the duration. Sometimes we have to use, sometimes few years, and there are studies clearly it reduces the progression of the disease. And the growth and nutrition is very important. I'm not going to do the details because lung growth is directly proportionate to the linear growth. So as you all know, these chronic lung disease patients, their respiratory rate is high, their metabolic demand is high, and they are having recurrent respiratory infections. They are usually ill, and because of that, their oral intake is low, as well as some times like cystic fibrosis like conditions, absorption is low, and all these things, and cystic fibrosis, the salt loss, is lost through the skin as well. So all these things lead into increased demand as well as reduced intake. So lead into finally nutritional issues. Almost all these children in our setup with established bronchiectasis or chronic lung diseases having nutritional issues. So always address the nutrition as well as growth is important. And some countries they use this even adolescents, if the nutritional thing is not growing happening properly, even for the feeding purpose, insert gastrostomies, and overnight they give use this through the gastrostomy, overnight nutrition, even in older children. Then the specific treatment like pancreatic enzyme supplementation in cystic fibrosis, it's not only the lipase. So it's lipase, proteases, amylase. All these things are deficient. So this pancreatin, or the crayon, that is the brand name that we are using most of the time, contain all these three, and the strength, the international unit. So mainly using 10,000 international units in our setup, the small children, that is pancreatic lipase, but don't forget it contains proteases and amylase as well. All the three main categories of enzymes are there. And importantly, so it is very, very important to identify these children early and start treatment, especially cystic fibrosis like conditions. This type of interventions might cause dramatic change. So this is a true CHDR of a child who had a meconium ileus and diagnosed to have cystic fibrosis in the early part of the life. And I came but even that diagnosis, the pancreatic enzyme supplementation was not optimum, but with proper optimum pancreatic enzyme supplementation, you can see the very clear significant improvement in growth. So this type of dramatic thing can happen if you identify these children early as well as intervene early. Another important thing is sometimes these children might have reversible airway component as well, but not all children with chronic lung diseases do not have asthma, but some children might have. So it's very important to, if there are showing features, do spirometry and bronchodilator reversibility to diagnose this thing. But some diseases like bronchiolitis obliterans or PCD or cystic fibrosis itself, these diseases already having component of bronchial obstruction, and that is also important to identify, quantify, especially use the FEV1 value. For example, assessment of the progression of the bronchiectasis or the disease in cystic fibrosis, FEV, use the FEV1. And for example, if FEV1 is less than 30% in cystic fibrosis, that is a very clear indication for lung transplantation. So it's important, and if there is any evidence of reversible airway disease, we can use inhaled corticosteroid and some inhaler bronchodilator agents, XOS. But we use regularly inhaler bronchodilator agents as a facilitator for airway clearance if there is any component of reversible thing. But other important thing is if there's established bronchiectasis with colonization, if there is no obvious reversible airway component, giving inhaled steroid might worsen the conditions. But sometimes because of, as there's no other option, no, we might not have some sort of sophisticated investigation. Because of that, almost all these children we are using inhaled corticosteroid or combined inhalers, but that is not a suitable thing in some children. So in these children, assessment, so inhaler technique is important. Always ask to demonstrate the inhaler technique, check it at least ideally every visit, but at least once in few visits. And some of these patients use home nebulizer, so you should be very clear about what are the drugs they are using, what is the dilution, what is the method, what is the frequency, and how do they clear. All these things are important to have a proper management plan. And the monitoring is very important. Growth is very important. As you know, one of the single clinical indicator which give idea about the degree of chronic lung disease. If the child is growing well, then it's very, very unlikely to have a significant problem. And the pulmonary functions are important. Spirometry, sometimes we have to do diffusion scans, lung volume, especially with plethysmography, 6-minute walk distance, that is to identify the physical exertion capacity, or we can do a proper exercise test, especially to identify early hypoxia and exercise intolerance. I'm not going to the details of these investigations. So regular pulmonary function tests are important, and especially as I mentioned earlier, some sort of obstructive air disease, monitoring of FEV1 is important. And the chest imaging, again same, we might have to do chest x-ray and maybe frequent, not frequent, but once a while CT chest to identify the current situation, especially if you suspect clinical progression or complications like ABPA in these children with established bronchiectasis. And microbiology, we just discussed sputum culture, so the soap culture, so the cope soap, and sometimes, especially if you still suspect if the lung functions are declining, if there is no obvious growth, but other countries they do interval bronchoscopy also to do the BAL to identify the microbiology of the airway. And so like this, Pseudomonas is one of the important colonizer or the pathogen which cause lung damage. Non-tubercular microbacteria, this is one of the important culprits which accelerate the lung damage, but unfortunately our setup, we don't have that much of sophisticated facilities to identify these organisms. And Burkholderia, another culprit, especially for example, if the Burkholderia cepacia is or some sort of Burkholderia organism is having or they have identified the disease, active disease, after active treatment with IV antibiotics, have to give nebulized meropenem for 18 months, 18 to 20 months. Like such a sophisticated methods are we going on. That is mainly because this type of infections completely, very clearly damage the lung. NTM is also same. Once this diagnosed, minimum treatment duration is 18 months of antituberculous medications. So they might need some sort of long-term antibiotics, especially this type of infections happen. And the other things, complications, monitoring for the possible complications, we have to expect these complications. One thing is echocardiography, that is to identify development of pulmonary hypertension. Sleep studies, against the ideal method is the full polysomnography, or maybe at least some sort of oximetry to identify early hypoxia, because interventions providing oxygen is one of the most important interventions to delay the progression of pulmonary hypertension. If they are already hypoxic, especially during starting with night, providing oxygen during night, because the reason to develop vasoconstriction or development of hypoxia is, or the pulmonary hypertension is hypoxia. So preventing or the treating for hypoxia with oxygen is the main method to dilate these vessels and prevent the progression, further progression of pulmonary hypertension. And we have to consider other organs, especially cystic fibrosis like conditions, liver scan, blood sugar, obviously can end up with diabetes, endocrine involvement, ABPA, allergic bronchopulmonary aspergillosis is a condition. It's not a primary disease. It cannot develop in a children, normal children. ABPA is developing in children with asthma or cystic fibrosis or established bronchiectasis. If the condition, especially children with asthma, if the control is going out, so then we have to consider possibility of developing ABP. Then the other normal physiological growth, puberty, those are also important monitoring. And apart from this physical monitoring, so we have to focus on their functional impairment, schooling, social aspect, and most importantly, the psychological aspect of especially children, especially older children, not teens. All these things we have to focus in as a comprehensive management plan. And this type of specific treatment are there. For example, cystic fibrosis, the problem is with the say CF, the molecule, the chloride transporter. There are some sophisticated new treatment modalities are available. These are even not freely available in other countries. So just to mention, this type of some sort of specific treatments are available for some diseases, but most of the time it's a supportive therapy. The final thing is, once they develop hypoxia, so we have to consider possibility of providing oxygen supply. But here also it's very important to identify what is the exact thing. If it is only hypoxia, obviously yes, the method of management is to provide home oxygen. But if the later of the disease, sometimes in the significant lung damage happen, and sometimes even the might be lost to follow up or defaulted follow up when the child coming back, you might have hypercarbia as well. That type of situation, just providing home oxygen only, might accelerate, as you know, further damage thing or accelerate the dying process. So because of that type of situations, we have to provide NIV. Both we have to address the hypercarbia as well as hypoxia. Other thing is like neuromuscular conditions. Obviously, the primary problem is respiratory drive. That type of situations also providing simple oxygen might worse the condition. So this type of situations, first thing we have to consider whether this is simple. The providing simply oxygen would be enough, or have to provide some sort of a non-invasive ventilator support, home support. So how do we provide oxygen? We have two methods. In now it's about even laypersons now know about this oxygen supply method because of this COVID situation. Oxygen cylinders are the easiest method, very practical method. But the thing is, long term it cannot continue. Other important thing is providing this home oxygen. We have to have. Usually we face two types of children. Forget about this chronic lung disease. One thing is, some children, they might improve. For example, neonate who require oxygen supply for prolonged durations, and usually if we want to send this child with home oxygen, we expect this child might grow out with this oxygen in maybe few months or few years. We also have few children. Recently, we had one child, significant lung, that is most of the time, most probably a interstitial lung disease, but we didn't do a biopsy. That child was on oxygen for 2 years. Now only that child is off oxygen. But providing oxygen, we prevented development of pulmonary hypertension in this child. So Sri Lanka also that is now happening. That is practical. So that category of child, or a child may be say presented with a severe pneumonia or bronchiolitis thing, required ICU admission and require oxygen and now oxygen dependent. We can discharge this child with home oxygen, but we assume this child the oxygen, the supply or requirement of home oxygen might be for short duration. That's the first group. That means we expect these children grow out of this oxygen. Other group is children with established bronchiectasis or chronic lung diseases and now hypoxic. So that they are gradually going downhill. So these children, rest of the life, they require oxygen. So that's a almost permanent thing. So for that type of situations, we have to go for some sort of long-term thing. For that, this concentrator is the ideal method. So what are the advantages of this oxygen cylinder? First thing is the initial cost is low. Second thing is mobility. So it's we can they can carry the oxygen even so adults. So we don't do this in our work setup. We don't have these small cylinders which are some of them are made of some the very heavy plastics, so they can stand the high pressure. So it's produce some sort of greater degree of mobility with oxygen cylinders. As you know, even these parents we transfer or they are coming to the hospital with oxygen cylinder. We cannot provide that with the uh, this concentrator because it need power supply. But now battery operated concentrators also there. Sometimes we might use it for about 4 hours. So those are the advantages of the cylinder. Other thing is cylinder, we can go up to 15 liters per minute, very high oxygen amount, especially if there is any emergency situation. But usually these concentrators, usually we can go up to 5 liters, but high concentration, these things are also present, but usually not practical to use in home setup. Other thing is not important because if child require significant amount of oxygen, maybe say 5 liters or more, obviously we cannot discharge that child with home oxygen. Ideally 1 to 2 liters, maximally 2 liters, the practical setup, we can discharge. Otherwise, we cannot discharge these children if they require more oxygen. That means they are unstable, they're having disease, and very high chance of coming back to hospital is very, very high. As you know, the most obvious disadvantage is with this cylinder is it need refilling depend on the use. Usually, maybe every other day have to use a new cylinder or they have to refill. Another thing is it's not require power supply. So oxygen concentrator, this use the room air and it require power. So there's some filtering mechanism is going on. It remove the nitrogen component of the room air and absorb or concentrate oxygen component and provide. Usually our usual concentrated can go up to 5 liters per minute, but high flow concentrators also available now. So the advantage is no need to provide or the refill these things. We can continue without refilling, but power, the cost for power is high and the initial cost is also high. For long-term things, this is more efficient. And before starting these things, so there are important things. You have to explain the condition to the parents, explain the prognosis to the child, and explain the available options. And home safety is important, especially about the fire safety. Oxygen, obviously, you know this fire thing can induce fires, and especially we have to inform the fire brigade and local authorities. Ideally, other countries they do home inspection as well before providing oxygen, and if it is not satisfactory, they ask to do some sort of home modifications as well. Other thing is because we are sending a child with oxygen, so they can have all acute exacerbations or deterioration at any time. So we have to inform the parents how to identify signs of deteriorations. They might use home management of pulse oximeters. Now it's widely available, and the clinical features increased respiratory rate, increased breathing, or change in the breathing pattern with evidence of increased work of breathing. These are very important, and we can ask them to just for the time being just increase the oxygen supply, but don't keep children at home if they show evidence of deterioration while keeping a higher concentration of oxygen. Just straight away come to the nearest hospital, nearest government hospital. That's the best method of advice.